with the plan. All right, so class today is being recorded, so let's continue with our presentation on shock. So when we talk about etiologies of shock, remember we talked about causes of shock. Basically what we're looking at, and we're going to look at some specific types of shock here in just a little bit, but basically what we're going to do is that we're going to focus in on the underlying cause and not so much the signs and symptoms. That doesn't mean the signs and symptoms are not important, but what that does mean is that we're going, if we can fix the problem, then we're going to fix the signs and symptoms as well. So that automatically just kind of comes through. Now, fixing the problem depends upon what the problem is, the type of shock that the patient is in, and that will guide our approach as far as what we're going to do. Now, keep in mind that your patients don't come in nice, neat little packages that only have one problem at a time. Patients, just like people, are very complex beings, and as a result of that, they may present with a cardiac history and anaphylactic shock, or it's potential that they could have multiple different forms of shock going on at the exact same time. We can see this in particular if a person has some type of an anaphylactic reaction while they're driving and then they wreck. And as a result of that, now we have anaphylactic shock and hypovolemic shock. So you may be having to approach that, Nico, from several different directions at the exact same time as you're going through your assessment and taking care of your patient. Don't get, it's easy for this to happen to new pre-hospital providers, but don't get lulled into yourself thinking, I only got one problem that I got to focus in on. You're like the juggler at the circus. You've got multiple priorities that you're trying to address and to maintain, Landon, while you're taking care of your patient. I like to say that your patients have not read your textbook, so they don't know how they're supposed to act. And so they will present with some pretty weird things. And at some point in time, and you'll hear me with this little saying over and over again, especially those of you that are going on to the paramedic program, is that at some point in time, you're going to be on the side of the interstate and you're going to look at your patient and you're going to say, I don't have clues what's going on. But if you can critically think through addressing the issues that are causing it, then you can keep your patient alive long enough to get it to somebody who does have the skills and the knowledge and the capability of addressing and fixing that. Keep in mind that in some circumstances, you're going to need ALS backup. Now, that may mean not so much that you're going to wait on the scene for the patient for ALS to get to you, but it may mean that you would do an intercept. So basically, on the way to the hospital, you're requesting ALS backup. And Landon, you may say, meet me in the parking lot at 368 Main Street, okay? And it's at that point in time that most likely the medic would get onto your truck. It would be simpler to happen rather than trying to move your patient. Although it all depends upon how your trucks are equipped as to whether you've got ALS equipment on your truck as a BLS provider. Don't be afraid to call for ALS backup, but don't abuse it. We're in a severe shortage right now of both EMTs and paramedics. So it is highly likely that if you call for an ALS intercept, it's going to be several minutes before they can get to you. In that situation, if you can be to the hospital quicker, even though you're providing a lower level of care, not a lower quality of care, but a lower level of care, that would be the best thing that you would get for your patient. Make sure when you do that, you've calculated the risk versus benefit ratio of waiting versus just simply going on to the nearest appropriate facility that you're going to transport your patient to. Again, you must be able to justify your decisions, okay? One of the things that you'll go through is through a QA/QI process, and all of you will, regardless of whether you're going into EMS or you're going into exercise or sports science. Somebody is going to be looking at what you did for both the good things and the things that could be improved. That's not a bad thing. That's a really good thing because we want our systems to continue to improve as we go through. But if someone comes and they simply ask you and they say, Zach, tell me why you did this, be able to give a rational explanation as to why you sat on the scene and you waited an extra 15 minutes for ALS when the hospital was 20 minutes away. And so here's the thing about making decisions. You'll get better at making good decisions after you've made a series of bad decisions, as long as you learn from those, okay? So I stress to students on a regular basis, make sure that you're making new mistakes every day because you're learning from your old ones and you're not repeating them. And that's a good thing. So let's talk about different categories of shock or different types of shock as far as when we look in here. When we talk about hypovolemic shock, we're talking about there is not enough blood in the circulating system to keep pressure up high enough for the organs to be perfused. Now keep in mind that the traditional normal blood pressure of a patient is 120/80. That may be high for some people, okay? That may be low for other people, but that's kind of the area that you're looking at. The blood pressure must be sufficient enough to get blood into and out of the organs, James, in order for that perfusion to take place. And in the process of perfusion, remember, Jaquan, we have gas exchange, CO2 and O2, and we have glucose delivery. That's extremely important when we're looking at this. Now, there are several things that can lead to hypovolemic shock, but the most common of this is going to be uncontrolled, serious bleeding, okay? The medical term for serious uncontrolled bleeding is exsanguinating bleeding. Exsanguinating bleeding. EXSANGUINATING. Exsanguinating hemorrhage. Now, this comes about primarily due to either blunt or penetrating trauma that causes a disruption in the flow of blood within the body. We can also get serious bleeding when we have fractures of long bones, in particular, the femur. The femur is the largest bone in the body, and there's a lot of blood that flows through the femur. So if you have a fractured femur, you can have some serious blood loss. The other place that we have some concerns about fractures is the pelvis. The pelvis is interesting in the fact that it's kind of shaped like this, all right? The weakest areas are the front of the pelvis and the back of the pelvis. Almost always, Jack, when we have a fractured pelvis, it's going to break in 2 or more places. And usually it's going to be in those 2 weak areas that I just talked to you about. Generally what's going to happen is that when that happens, the pelvis kind of flops over like that. That's called an open book pelvic fracture. Patients can bleed to death from pelvic fractures. We'll talk more about them when we get into orthopedic emergencies, and I'm sure that you will be talking about how to stabilize and immobilize pelvic fractures once you get in the lab. Yusuf, did you have a question? Okay, all right, my bad. So the other thing that we're looking at here is serious vascular injuries, such as amputations. Folks, I'm going to tell you, for all means and purposes, when you have an amputation, you can try direct pressure, but it's probably not going to work. So I would encourage you to follow the lead of the military. I just get a tourniquet put on your patient right away. Okay, just start that tourniquet, and we'll talk more about that, and you'll definitely talk more about that in your lab. Different organs in the abdominal cavity are very, very heavy as far as full of blood. Hopefully you know that your liver is on the right side, spleen is over on the left, okay? Liver and spleen are solid organs, and they will bleed profusely if they are injured. Generally what will happen is sometimes people will go in for like a liver biopsy, and they're putting just not a really very big needle into the liver itself to make sure maybe the patient's got cancer, maybe they've got some type of liver failure that's going on. But they will make those folks lay still for hours simply because of that needle going in and the potential for bleeding. So imagine if you've got like a 38 caliber handgun projectile that goes through your liver or even into your spleen. Imagine the damage that's going to do. And as a result of that, now what we're going to begin to see is massive internal bleeding. Little hint here for you. If your patient is hypovolemic, let me back up. If your patient is hypotensive, meaning heart rate is up and blood pressure is down, and you see no external bleeding, James, think that he's bleeding, or she, in other words, bleeding somewhere in the abdominal area or in the chest, okay? Abdominal area or chest, if you've got a patient that's going to be hypotensive. Now, we can also get hypovolemic shock that comes about as a result of loss of fluid, okay? You were talking about the fluid diet or water diet that you went on, and you said at the end of it you kind of felt like you were a raisin. So basically, the more water we drink, the more water the body offloads. So you probably, even though you were drinking a lot of water, you probably were dehydrated at the end of this. This is a situation of where a patient can have hypovolemic shock and have absolutely no trauma and no blood loss from that as well. So when we're looking at this, some of the situations where we would see this begin to happen would be with patients that have serious burns. So the skin begins to get burned away, and as a result of that, the vessels now begin to leak. And the fluid that the vessels are leaking is not the red blood cells, but it's leaking the plasma. Now let me ask you a question, and I'll throw this out to everybody. How does that cause hypovolemic shock if the patient's not losing blood? Not everybody at once.
It's because you'll start clotting up.
Okay, so the blood does become thicker and potential for clots does go up exponentially. So you're exactly right. So that's another issue that we would be concerned about with this patient as far as we're trying to take care of them. But what else would happen?